Hello, everyone. Dr. Nikhil Verma here with another episode of Things I Didn't Learn in Med School. Today, I wanted to talk about a topic that Theodore Tran, who is a medical student at the Medical School of California University, um, he reached out to me on LinkedIn and he brought up this very interesting question. He said, Dr. Verma, I want to know your thoughts about what is the single or some of the most significant issues in healthcare we face today. He briefly gave an example of Dr. Peter Attia, who has a podcast, I think it's called The Drive, where he talks about healthcare and health industry and talks about optimal living and uses a very scientific approach to longevity. That's kind of what his whole thing is about. Interesting podcast. A lot of the things that he doesn't really have as much evidence as he likes to think it does, but I think he's doing the right thing about how he's approaching it. And he's the type of person that lives it. He tracks the data and shows the results. He's transformed, lots and lots of people's lives. He's a private physician, kind of doing concierge medicine in that sense. So, this isn't to say that much negative about him. I still do appreciate what he does, and I think he's a very intelligent person. He's gone to a very sought-after medical school and highly regarded residency program, et cetera, et cetera. So much smarter individual than I am when it comes to a lot of things. But yeah, so check him out if you have any interest. But anyways, so Peter Attia's thoughts was that there's lack of transparency. I'm going to pull up what Theodore had explained to me is, Dr. Attia discussed the lack of transparency regarding insurance pricing for patients, as well as the inefficient medical training system we have today. I want to highlight two of those points. I don't think the problem is with price transparency. Now with the No Surprise Act, we have these prices out there, and I don't think that stopped anyone from doing what they do. So that's something to keep in mind. I don't know if that's an adequate solution to anything, of just if that's actually a problem. Now I think that it's part of the solution. I think that's a good thing that we are showing patients and people in general what people are charging for different things. But ultimately, if a primary care center in a small town versus a tertiary care center and a university city have highly varying rates, and it's much cheaper to do a primary care setting in a small town versus the tertiary care, people are still going to choose to go to the tertiary care center because it has that university name behind it. So I don't know if that transparency thing causes anything. My solution to this would be, instead of having one central mecca where, I'll just give an example of Ohio State University, where they continue to build these massive multi-million, hundreds of $1 million buildings, and it's all centralized in central Columbus, Ohio. In my mind, why wouldn't it make more sense to expand these out to 15 miles north, 50 miles east, 50 miles west, 50 miles south, and et cetera, et cetera. And we have now all these surrounding areas with the best doctors and the best staff, and it can all be ran through a central hub and have conversations and stuff. But at least now patients aren't driving 45 minutes into the city just to get the treatment they need when they can go somewhere a little bit further away. I think this is starting to happen. And you see a lot of small pop-ups of smaller branches of universities or smaller branches of hospitals moving around in different parts of the U.S. Give Ohio State as another example. Is they started opening up regional branches throughout the Central Ohio area. Cleveland Clinic has expanded from northeast part of the state, and they've started expanding south and really expanding out. They have imaging centers in Columbus. They even have treatment centers as far south as the southern part of Ohio. So these are helping. But that's on one hand. On the other hand, the problem with this is all these big hospital centers, these private equities groups, when they conglomerate like this, what it actually does is it causes a bigger problem down the road where they take these negotiations with the insurance companies, and they say, hey, look, we have all the best doctors. They work in our hospital system. You want to give us the best rates. So they go and inflate these rates of what the treatment should cost. And this is probably what Dr. Attia was alluding to. This is probably a big thing that we all need to start discussing. So they give these hospital centers these big rates and the better reimbursements than you would get as an individual private practice doctor. Now, this happens all the time. This is an uphill battle that I'm dealing with, and this is why private practice doctors either join a private equity group, or join a hospital university center, or they join a university, or ultimately, they might join a multi-specialty organization that kind of handles everything in the back office. So you, as a physician or provider, can go out in the front and take care of your patients, and you don't have to worry about all that other stuff. So these are kind of some of the solutions to those problems. But I don't know if they're enough. I think one of the intelligent things, in my opinion, would happen is, as unpopular as this might be with physicians, is actually establish some sort of union and utilize this union as a working force in the American healthcare literacy, healthcare advocacy, physician reimbursement, and stop reimbursing hospitals and CEOs and C-suite executives so much money. Not saying that all of them are evil, but that tends to be where all the money goes. If you ever have some curiosity and go look at what the CEO or the COO or some of those other individuals in the C-suites make at these hospitals, and you'll be like, why is this person making that much money? It's like, they're running an organization, sure, but shouldn't that money be redistributed to the workers in the hospital, or redistributed to the patients that are working, that shouldn't be paying for all this stuff? I know that kind of sounds like a socialized healthcare, but it really isn't. It's just redistribution of where the money should go, and this could help alleviate different types of burnouts and could help alleviate different types of issues. So anyways, those are a couple of my thoughts on hospitals, PE firms, and the huge problem. Another problem that we're facing in the healthcare industry are the lobbyists. We don't really have lobbyists arguing on the behalf of physicians and providers. We have advocacy groups in each of our own little niches of medicine. For example, Spinal Interventional Society has a big group that's trying to work with Congress, and I'm sure all the societies and groups and assemblies and whatever you want to call them, they have these government liaisons that go work on the behalf of us as individuals. But the lobbying is really dominated by bigger groups that can afford these kind of things, and that would include some of these really, really big hospital systems and some of the bigger players in town. And unfortunately, also has to do with how much revenue that branch of medicine can make. For example, orthopedic surgeons and neurosurgery and spine surgery, they have a really high reimbursement rate, so they have a lot more money, and they can afford to give the money to lobbyists and to help advocate for them. So that's just something to keep in mind. I think that's another problem. Again, the topic here is, what are some of the most significant issues in healthcare that we face? And the other people that have the lobbyists are the insurance companies. We know that these insurance companies are making billions of dollars a year now, and there's no looking back. Like, they continue to make hand over fist in profits every year. So, and what we're noticing now more and more is that these insurance companies are dictating our healthcare for our patients. I can't even tell you how many times this has happened about a denial that should not have been denied by an insurance company, or a procedure or imaging that was approved for one of my patients, and it was approved, but she was out of town, couldn't make her appointment, came back. I tried to get another approval. Oh, you need to resubmit it. So I resubmit the claim. Now it's denied. How does that make any sense? It was already approved. The patient had other obligations to get to. Insurance companies denying care for sick children, cancer patients, for broken bones. The idea of a kyphoplasty having to go sit and wait is ridiculous to me. If you have a fracture in your spine, well, let's talk about this. If you have a fracture anywhere else in your body, you're probably going to get taken care of, right? Some sort of casting, go get the imaging, make sure that there's no nerve damage, vessel damage, etc. But you're going to get some sort of adequate treatment, right? Well, the kyphoplasty is like, oh, well, just go sit in a brace and wait for a few weeks. Now, for the small percentage of them that do better with that, that's fine, but not everyone does better with that. So to have them sit around for 6 to 8 weeks with a broken bone and you can't do anything, you can't move, I don't know how that is beneficial for anybody. Letting insurance companies dictate how we manage care, denying even medications, you have to get prior authorizations on something as innocuous as NSAIDs, non-steroidal anti-inflammatory drugs, and sometimes some muscle relaxers. If it's not the right dosage, or if that one's not in formulary with that insurance company, they'll deny it. So it's like this stuff doesn't really make sense, especially because these medications are cheap to make and they can be abundant and they can help people dramatically. And people have different reactions to different medications because there's different fillers and different agents in there that patients might react to poorly. And I think that's a good transition to the next one. Is just the general lack of education that we have for patients is astounding, from patient to patient to county, and it's tough to have patients advocate for themselves given how much can go wrong. But sometimes a lot of patients just come to you and they're like, I just want the solution. And you can't sit there and blame the patient because so many things have been thrown at them that, oh, this is supposed to help you, this is supposed to help you, go to this specialist, go to this specialist. But no one's actually given them any direction or path. And then after a few years of dealing with it, they get frustrated, they get upset, they lose faith in the system. And I think having better education, having better communication with our patients, having more time for physicians, nurse practitioners, PAs, physician's assistants, nurses, advocacy groups, educational groups, just any type of information that can be presented to the patient. And everyone's a different type of learner. We have learners that will read, some that from experience, some from a lecture series, some from videos, some from actually doing. So, we have to have all these available for patients to understand, not only patients, but ourselves to understand as physicians, as we communicate across to different specialties, and have meaningful conversations and allow us to help our patients. Like, hey, I'm not an expert in cancer, but it would make me feel better if we did these scans, and have that kind of conversation with the patient. But I wouldn't even know what to say because I don't know all the different types of cancers that may be affecting my patient. Sometimes that can get lost in translation. So that's just another significant issue that I see we're facing. Then the other is the lack of care, especially in our underserved communities. This goes back to education and care. It's like everyone wants to sit here and blame obesity or blame people being lazy or not having, not exercising. It's like, that's easy for us to say when we have everything that we want in front of us, but that's not the realistic way most of American society works. Most people are working 2 or 3 jobs. They're not living in big houses, in big community centers. They have kids to feed, and maybe the only thing they can pick up their kids for lunch or dinner is that chicken nugget meal from McDonald's. It's just so easy for people to say, oh, just simply do this, do that. And it's like, well, you have to look at the circumstances. In these same patients, especially the more rural you get, the less likely they're going to come to see a physician. And that's been shown over and over again, that these areas of healthcare discrepancies, and it gets even worse if you start adding in racial norms to it, where due to the Tuskegee study, we know a lot of African Americans have distrust in the medical system. There's other cultural conditions that we may not understand that might be prevalent in a community, or there could just be kind of upbringing of oh, we don't go to doctors because we try to figure everything out ourselves. Like all these kind of things put into play. So the lack of care, especially in these rural communities, it could go a long way. It could really help generate people to a better direction. It could help increase outcomes, et cetera, et cetera. And this was the big idea of why they wanted to have increased nurse practitioners and physician assistants out there, because they're like, oh, it's great. We'll have more access to care. They'll put them in more community-based areas, and it'll be great. But as we see further and further from when this proclamation started, the less and less that's happening. It's not as lucrative. It's not as appealing. Most of these people want to live in cities. They want to raise their kids in cities, et cetera, et cetera. But so, it's a big problem. I don't know if I have a good solution for it. I think there could be different ways to approach it, but I don't know what a good solution is. That is a major barrier that I'm seeing, a significant issue in our healthcare industry. And it's not just us. That happens everywhere. I've been to India where, one of my families, they have drivers in India, and one of the drivers of the family had some sort of foot infection, gangrene, and I was like, he needs to go see a doctor about that. And he's like, well, we live all the way out here, and our culture doesn't believe in doctors, or we just believe if we pray in it, it'll go away. So it's like, these things is not isolated to the U.S. healthcare system. It's a worldwide healthcare system issue. I think medical record systems are causing all types of problems because now they're so easy to be audited. It can take a computer system, a smart computer system, do an audit and cause problems. So now physicians and nursing staff and hospital administration and everybody has to work more time on the front end, making sure that everything's right in their notes. This can cause problems in billing cycles and revenue control and all that stuff. So a lot of times physician offices are trying to get as much revenue generated because they know a lot of their money is going to be tied up in accounts receivable, and it hasn't been paid on time, or there's something that's wrong with appeals, or something that needs appeal. So, I think that EHR is making that process easier for the insurance companies and the government to audit and less beneficial for the patients. And also, I thought about it today. I'm sitting here and talking to my patients. I almost never take my laptop into the room, but, a couple patients went a little long today. So I'm sitting here, like, all I thought about is I need to go out and write this note. I have to sit here and purposely redirect my attention to what the patient's saying, what the physical exam looks like. It just gets to a point for me most days. I'm like, I'm just not going to write any more notes today. I'm just going to take it home and work on it at night. It's not a way we should live life. That we shouldn't be sitting here working for 10 to 12 hours a day, then going home and writing more notes for 4 or 5 hours. Like, that's no way to live life. And I think the medical record system has completely ruined that for many physicians out there. Not only that, it's a mandate from the government. You need to do it, and it costs a lot of money. So if it's a mandate from the government, it should be free. That's how it should be. It shouldn't be that we're paying lots of money, and then all these medical record systems want to come out with their fancy gizmos and gadgets and apps that you can download and make it. Like, no, it's just you're just doing this because so you can charge a higher price, and that's the only reason you're doing it. The other big thing is we can talk about the prior authorizations. I think I briefly talked about it. Still, just want to reiterate, it's like, this process is ridiculous. Like, sure, maybe 20 years ago, 30 years ago, people were abusing, oh, I want to get MRIs, I want to order this, I want to order that. But now it's like, we shouldn't be punishing every patient for getting a prior authorization. We should just simply be able to do what we feel is medically necessary as long as it's within some sort of guidelines. Whether that guidelines be of what your society says or what the CMS guidelines are or the local coverage determinants guidelines. But we shouldn't have to sit here and try to second guess ourselves and get denials from insurance companies to dictate our patient care. And the last thing I want to talk about, I've talked about this on another episode, is just physician reimbursement has consistently went down for the past 20 years. CMS continues to cut physician reimbursement, and in a significant portion. And not only that, inflation continues to rise. So, from 2021 to 2022, or 2022 to 2023, we're looking at, 10 to 20% pay cut at least. Hopefully it's not more than that, but that's kind of where we're at. And if we don't band together as physicians and try to do something about this, then we're going to take a major pay cut. And this is only going to continue down the road. So again, I think a couple of solutions I had is try to figure out, some sort of union for doctors. I think DocNation is one of the groups that I know is kind of doing this to try to get some physicians together, some pull some steam, making some groups that we can take to the government, show our data, show our results, and see if we can help our patients more and more. So that's about all I have to talk about tonight. I hope you guys found this useful. If you guys have questions out there, please message me, DM me, drop me a comment on the YouTube channel, whatever you want to do, and we can see if it's a topic that I have any interest in. If not, I'll go read about it and try to help you guys out. Again, if you guys find this useful, please share it. Please subscribe, and I hope to talk to you next week. Take care. Bye.